Once the patient is prepared and draped, the bony face anatomy should be outlined with a surgical marking. This includes the clavicle borders of the acromion. Anteriorly, posteriorly, and laterally, the spine of the scapula, the acromioclavicular joint, and the coracoid. At Fig 1, all expected portal sites should next be marked. For a basic diagnostic arthroscopy, these should include a posterior, anterior, and if necessary, lateral portal. Accessory portal locations required for specific procedures will be discussed in subsequent chapters. Black square posterior portal, 2 to 3 cm inferior and 1 cm medial to the posterolateral border of the acromion. It is usually located in the soft spot of the posterior shoulder. That can be palpated between the posterior rotator cuff muscles, infraspinatus, and teres minor. Black square anterior portal. This portal is marked just lateral to the tip of the coracoid process and inferior to the anterolateral acromial border. Care must be taken to ensure that all anterior portals are lateral to the coracoid to avoid damage to the neurovascular structures located medial to the coracoid. Black square lateral portal. This portal is marked 3 to 5 cm lateral to the lateral margin of the acromial border. The low cathion of this portal may change based on the intra-articular anatomy. Black square. Before starting the arthroscopic procedure, the surgeon ensures that all arthroscopic equipment, arthroscope, monitor, pump, is properly functioning. The posterior portal is created first. Black square. A 5 mm skin incision is made using a number 11 scalpel. Black square. All shoulder arthroscopy incisions should penetrate only the skin and no deeper, to avoid injury to new revascular structures and possible damage to articular surfaces. Black square. The arthroscope sheath and blunt obturator are then inserted into the glenohumeral joint. Fig 2. Black square. The trocar should be directed toward the coracoid. One hand can be used to stabilize the shoulder, and the index finger used to palpate the coracoid tip. Black square. The obturator should be directed just medial to the humeral head and into the space between the head and glenoid. There should be a pop once the capsule is penetrated and a cannula is within the glenohumeral joint. Black square. Some surgeons prefer first to inject saline with a spinal needle into the glenohumeral joint. This hands the joint and allows a bigger target, as well as, with fluid return, confirms that the arthroscope is in the proper place. Black square. The irrigation system and pump is turned on and the humeral head, glenoid, and biceps tendon are identified. For quick orientation. Black square. A brief inspection of the glenohumeral joint can be performed to determine whether modification of the subsequent portals may be required. The anterior portal is next created. Depending on the intra-articular shoulder pathology to be addressed, a modified anterior portal may be needed. This is discussed in other chapters. Black square. For most standard arthroscopic procedures, the anterior portal may be created using either an inside-out or an outside-in technique. The arthroscope is placed within the rotator interval just inferior to the biceps tendon and held firmly against the anterior capsule. The camera is then removed while holding the cannula in position. Black square. A switching stick or Wissinger rod, a long metal rod that fits within the arthroscopic sheath, is inserted into the cannula and used to penetrate the anterior capsule and the skin. Black square, a small skin incision is made over the end of the switch stick. Black square, a cannula may then be passed over the switching stick and into the glenohumeral joint. A spinal needle is inserted at the expected site of the anterior portal and into the joint. Tech Fig 3. Once the needle is visualized and its location deemed adequate, it is removed and a small skin incision is made at the site where the spinal needle was inserted. Black square, a cannula with its obturator is used to penetrate the anterior capsule into the glenohumeral joint under direct arthroscopic visualization. Diagnostic arthroscopy of the shoulder begins with the arthroscope in the posterior portal and a probe through the anterior portal. From this position, the following structures should be visualized and probed. Black square, articular surfaces of the humeral head and glenoid. Black square, the cartilage surface is evaluated, noting any chondral damage. Black square, the glenoid cartilage may have a normal thinned out appearance at its center. Black square, occasionally, the demarcation of the two ossific centers of the glenoid may be identified as a thin line on the chondral surface. Black square, subscapularis tendon and rotator interval. Black square, the integrity of the superior tendinous edge of the subscapularis and its attachment to the lesser tuberosity is evaluated. Tech Fig 4a. Black square, the tissue quality and laxity of the rotator interval, the capsular tissue between the anterior edge of the supraspinatus and the superior edge of the subscapularis is noted. Black square, superior and middle glenohumeral ligaments. Black square, the superior ligament is evaluated as it crosses between the subscapularis and biceps tendon, and the middle ligament as it crosses the subscapularis tendon. Tech Fig 4b. Variants may include a Buford complex, cord-like middle glenohumeral ligament, or even absence of the ligament altogether. Black square, superior labrum and biceps tendon. Black square, the biceps tendon is evaluated on both sides, using a probe to pull it into the joint to evaluate for hidden synovitis or fraying that exists as it leaves the joint and enters the bicipital groove. Tech Fig 4c. Black square, rotator cuff. Black square, the tendons of the rotator cuff are evaluated with the arthroscope looking superiorly. The rotator cuff tendon attachment to the humeral head should be smooth, without any fraying. Tech Fig 4d. Black square, as the arthroscope is moved posterior-inferiorly around the humeral head, the normal bare spot on the humeral head is easily identified by the lack of articular cartilage and the presence of nutrient foramen in the bone. Tech Fig 4e. Black square, inferior capsule and recess. Black square, the inferior capsular pouch and the capsular attachment to the humeral head are assessed. Tech Fig 4f. Black square, occasionally a humeral avulsion of the inferior glenohumeral ligament may occur here with or without a fragment of bone. Tch Fig 4, a left shoulder in lateral decubitus position with anterior superior and anterior inferior portals established. The biceps tendon B is between the two cannulas. The humeral head H, glenoid G, and rear edge of the subscapularis S are identified. B, left shoulder in beach chair position with subscapularis S, biceps tendon B, and middle glenohumeral ligament hem identified. The anterosuperior labrum is highly Variable and in this case presents as a sub. Labral hole arrow. C. The long head of the biceps can be pulled into the joint to inspect. For synovitis arrows, as shown in this showl. Dare. D. The anterior edge of the suprapinatus. And the normal rotator cuff insertion are depicted in this image. E. As the arthroscope is swept posteriorly along the rotator cuff, the bare area of the humeral head is identified. This is a normal area devoid of articular cartilage. The transition between the posterior rotator cuff and the inferior capsule is identified. Arrow. F. The inferior capsular pouch is seen attaching to the humerus. This is a common area to find loose bodies as they tend to fall to the most dependent aspect of the joint. In the beach chair position. G. The inferior glenoid labrum can be visualized as the arthroscope is redirected superiorly from the axillary pouch. HI. The anterior labral attachment is inspected. H. The labrum and capsular attachment are normal. I. There is a disruption in the attachment of the anterior inferior labrum, Bankart lesion. J. The superior labral attachment is probed as the arthroscope is directed superiorly. The inferior labral attachment can be examined. Tech. Fig 4G. Black square anterior band of the inferior glenohumeral ligament. Black square, this is the primary static stabilizer to anterior glenohumeral translation. Black square, the anteroinferior labrum should be tightly tacked to the glenoid. Tech Fig 4H. Detachment. In this area is commonly referred to as a Bankart or Perth's lesion. Tech Fig 4I and will be discussed in greater detail in Chapter SM-2. Black square visualization of this ligament is facilitated when the ligaments and capsular tissues are loose and the arthroscope may easily pass into the anterior recess between the humeral head and glenoid. This is known as a drive-through sign and may represent multidirectional laxity. Black square biceps anchor. Black square, the superior labral attachment to the glenoid is probed to evaluate for a superior labral anterior to posterior slap, lesion 3. Black square, typically the superior labrum is well attached to the superior glenoid. Tech Fig 4J. Black square normal variants such as a meniscoid superior labrum and variations of the biceps tendon, bifid tendon, are not uncommon. They must be differentiated from pathoanatomy that requires repair. Arthroscope in the anterior portal. Black square, the arthroscope is removed while keeping the sheath in the joint posteriorly. It is placed in the anterior cannula to allow evaluation of the posterior joint and to assess the rest of the joint from another viewpoint. The posterior labrum should be smooth and tightly attached to the glenoid. Tech Fig 5. Black square, the scope is angled upward to assess posterior capsular attachment to the humeral head. If detached, this represents a reverse humeral avulsion of the glenohumeral ligament. Black square, subscapularis and biceps tendon. Black square, the subscapularis recess and subscapularis attachment to the humeral head can be evaluated. Black square loose bodies are occasionally found within the subscapularis recess. Black square, integrity and stability of the groove and the synovium of the biceps tendon are evaluated. UBSROMIL arthroscopy. burstoscopy. Black square once the diagnostic glenohumeral arthroscopy is calm. Pleated, the sheath and obturator are then directed into the subacromial space. Black square, this is done by placing the obturator tip just beneath the posterior acromion, and then inserting it parallel to the acromion. Black square if the arthroscope is inserted properly into the subacro mile space anterior to the posterior bursal curtain, then the distended bursal space should allow for visualization of the subacromial structures free. Black square at the surgeon's preference, a lateral portal may be created at this time. Black square the inferior aspect of the acromion is evaluated, and the coracoacromial ligament is identified. Black square the lateral and anterior aspects of the acromion are assessed. Black square the anterior acromial spur is evaluated if present. Black square the arthroscope is oriented to look downward at the greater tuberosity and attachment of the rotator cuff. A probe from the anterior or lateral portal is used to assess the rotator cuff integrity. The rotator cuff attachment should be smooth without fraying or thinning of the tissue. Black square internal and external rotation of the arm will allow for visualization of the entire cuff. Black square the acromioclavicular joint is evaluated. The distal clavi may be hidden behind thickened tissue. Further evaluation of this joint is discussed in chapter SM-8. Black square once the subacromial space has been evaluated and all pathology has been addressed, the arthroscopic instruments and cannulas can be removed from the shoulder. Black square the portals can be closed with a simple suture or subcuticular stitch. Black square wounds can be dressed, and the shoulder placed in a sling for comfort or for rehabilitation purposes, depending on the procedure performed. Postoperative care. Black square, the patient is placed in a sling for comfort. Allowable range of motion and exercises are tailored to the specific procedure performed and will be discussed in detail in the following chapters. Black square cryotherapy, a commercial ice unit, may be used. Outcomes. Black square shoulder arthroscopy is a safe and effective procedure. It allows for complete visualization of the glenohumeral joint and subacromial space and treatment of identified pathology. Black square outcome data for specific procedures performed are discussed in the following chapters. Complications. Black square failure to address all pathology with thorough diagnostic examination. Black square infection. Black square loss of motion or adhesive capsulitis.